So Professor Shari will now start the sessions of the videos of the sessions, and then after we can come up for a short discussion.
Perfect, Albertina, perfect. Greetings. It's wonderful to celebrate the World Skin Health Day with you in Guinea. Professor Robert Schwartz at Rutgers University, and I have the privilege of speaking on food allergy, more than a peanut of a problem. I have no conflicts of interest. I am a vice president of the International Society of Dermatology, a director of Alpha Mega Alpha National Honor Medical Society, editorial board member, American Academy of Dermatology, and international regional advisor of the Royal College of Physicians of Edinburgh. We thank King George III for beginning our university in 1766. We're one of 9 surviving colonial colleges. It's wonderful to be with you in Africa. This is a photograph of I took in the largest nation in Africa. And then what was the largest nation in Africa, which is no longer the largest because its southern part was removed. This is the nation, beautiful nation, with more pyramids than any other country. And here I am with the dean of the medical school in Khartoum. Food allergies may begin as a rapid onset of symptoms with hives or
So the sessions have started, and you can now follow them if you want.
In addition,
and then for the discussion is the second link that you have in your emails.
Meat allergies too, which Dr. Shaw and I Greetings. It's wonderful to celebrate the World Skin Health Day with you in Guinea. Professor Robert Schwartz at Rutgers University, and I have the privilege of speaking on food allergy, more than a peanut of a problem. I have no conflicts of interest. I am a vice president of the International Society of Dermatology, a director of Alpha
Okay, I'm going to go to the discussion.
National Honor Medical Society, editorial board member, American Academy of Dermatology, and international regional advisor of the Royal College of Physicians of Edinburgh. We thank King George III for beginning our university in 1766. We're one of 9 surviving colonial colleges. It's wonderful to be with you in Africa. This is a photograph of I took in the largest nation in Africa. And then what was the largest nation in Africa, which is no longer the largest because its southern part was removed. This is the nation, beautiful nation, with more pyramids than any other country. And here I am with the dean of the medical school in Khartoum. Food allergies may begin as a rapid onset of symptoms with hives, urticaria, angioedema, and an allergic dermatitis. In addition, we're concerned now about meat allergies too, which Dr. Shaw and I have labeled a ticking time bomb. We'll cover that in addition. The common food allergens are cow milk, wheat, egg, soybean, peanut, tree nuts, fish, and shellfish. Food allergy represents a psychosocial burden. In America alone, 1 in 15 kids are affected. It's a worldwide concern, a significant medical and a significant legal problem. It's an IgE-mediated hypersensitivity reaction to specific food protein in most cases. And of course, no nuts for me, I'm allergic. Please ask my parents first. You know, when I was a kid back home in San Francisco, peanut butter and jelly sandwiches were the routine lunch for kids. And of course, you can't do that anymore. People are attuned to the problem, which has become more prevalent. Marcus Davila, age 19, died after eating Chinese food cooked in peanut oil. Christina Disforgis died after kissing a boyfriend who ate peanuts. Well, how does food allergy develop? Well, we believe, for the most part, it's from ingested food absorbed immunologically in a normal gut. Intact foreign food proteins rarely induce symptoms. There's tolerance that develops. Bacterial flora influences the development of tolerance, and the flora is very important that's in the gut. You can also be sensitized by inhalants as well as through the gut. Immature gut mucosa probably accounts for the increased food allergy in children. So this is mostly IgE mediated. In the skin, you get hives, angioedema, rashes, flushing. In the gut, the respiratory tract, and generalized, you have other phenomena too, including dreaded anaphylactic shock and food-associated exercise-induced anaphylaxis too. So you may have a mixed IgE and cell-mediated phenomena, as in atopic dermatitis and other asthma. So peanuts are a major offender. They're native to South America. They've been cultivated for many thousands of years. They're a source of easily digested protein. I love peanuts, peanut butter. They used to be for livestock as feed up until the late 1800s in the United States, when clever entrepreneurs marketed them for humans. And of course, they're not nuts. They're legumes. They're used in plastics, in linoleum, in adhesives, in bleaches, in shampoos. They often cross-react with common tree nuts, walnuts, hazelnuts, almonds, cashews, pecans, pistachios. And people are acutely aware legally of the concerns. This is our local bakery, which services a small offshore island near where we live, called Manhattan. And again, it warns, all our products contain wheat. We are not able to offer gluten-free items as we would be producing at this facility, since flour dust is present. This facility also processes milk, egg, and tree nuts. While we do not process peanuts, the nuts we do use may have been prepared by our vendors on equipment that is also used to prepare peanuts. So common foods cross-react with peanuts, as I've indicated, including other legumes, the tree nuts, and sesame seeds. And these can be lifelong allergies. Kids may not outgrow them, particularly peanut, tree nut, and seafood. Food allergy and atopic dermatitis is important. IgE-mediated, mast cell-mediated, degranulated reactions occur to shellfish and peanuts. Food allergy is seen in more than 1/3 of childhood atopics, and it's more common in kids with moderate to severe atopic dermatitis. And more reactions to nuts and fish in this group as well, is noted. Elevated specific IgE to eggs has been suggested by some as a screening test. So why is there increased atopic dermatitis and presumably increased food allergies? Again, improved hygiene gives less immune stimulation. IgE lacks parasites, attacks pollens, food proteins, and mites. So we get excessive T cell activation to antigens. Langerhans cells hyperstimulate T cells. The pollutants shift T cell response. And of course, flares may occur from infection, whether bacterial, viral, or fungal. Food hypersensitivity is a big factor in the very young, with 5 foods the main offenders, specifically egg, milk, peanut, soy, and wheat. And again, this is peaking at age 1, so it manifests in infancy, declines after the age of 3. 6 to 8% of kids under 4 are affected. Over the age of 10, about 4%. So here we are, a swollen, unhappy kid. And this is actually, I was dining at a restaurant where, again, this was produced by the county, Westchester County in New York. Food allergies can be serious. Even a tiny amount of the allergy causing food can be harmful. Symptoms: loss of consciousness, shortness of breath, itching and tingling around the mouth, face, etc. Hives, swelling of the face, tightening of the throat, sudden onset of vomiting, cramps, or diarrhea. Ask the chef or the manager if allergy-causing food is in or came in contact with the dish ordered. Again, they recommend that the employees in the kitchen wash their hands, change gloves, clean work surfaces, etc. A serious issue. Diagnosis and medical history is the most important link. Oral food challenge can be effective, but it can be risky. I prefer the immunoassay. Peanut allergens are mainly, again, proteins on the catehedron. Catehedron has 8 identified, 2 the most common, and again, some of the configurations are more likely to produce severe reaction than others. Roasting peanuts does not necessarily save anybody. In fact, roasted peanuts have 22 times more extractable ARH1 than raw peanuts. My favorite restaurant in Warsaw, and I love Bobby Burgers. Notice double dressed by cheese. Notice the lettuce there. Because red meat can now be a problem. We haven't thought about it in the past. A ticking time bomb. Severe reactions 2 to 3 hours after red meat is eaten. The IgE antibodies are directed against carbohydrate epitope, characterized as alpha-gal, found in mammalian meat, producing anaphylaxis, producing hives, GI symptoms, and there's a history of a tick bite because the alpha-gal phenomena results from a tick bite. And of course, in Europe and here in this part of America too, ticks are a big concern. So allergy to beef, lamb, pork is rare, but increasing. We worry about fruit allergy. Peach, kiwi, cherry, grape, lettuce. Cross-reactive IgE to certain pollens. Allergy to fruits are linked to particular pollens. It's called the lipid transfer protein syndrome, with peach allergy often being the primary sensitizer. Soy, again, was mentioned previously, and again is a concern. Fish allergy, another major concern. But, it turns out, when it's looked into it, a good number of these reactions are really not to the fish, but to the parasite larva in the fish, in the codfish, the sardines, the anchovies, the salmon, the tuna, etc. So the prevalence of sensitization is even higher, a little higher in one study, as noted. So fish allergy, a common source of food allergy in kids, tends to persist. Inhalation of steam on cooking can cause this. Continuous monitoring is needed to avoid, and this certainly can upset the quality of life, can't it? Shellfish allergy, another common concern. Shrimp, prawn, crab are concerns. And these days they tell us, oh, you shouldn't be eating your pork anymore. You need to have edible insects. Well, insects, while alternative nutrient sources, it's true, but they cross-react with shrimp, mite, and flies. And IgE from crustacean allergy. Patients shows cross-reaction, house crickets, desert locusts, etc. So there's no escaping. Here I am in Vietnam, enjoying insects. I'm not sure I'm enjoying them, but I'm eating them. Here I am with another Polish American, a University of California Berkeley alumnus, who says to us and wrote to me, think different, the Woz. This is the man who founded Apple Computer, and we need to think different about this troubling, common problem. Thank you for attending.
Hi, I'm Rudi Chandra, dermatologist from Indonesia. It's an honor for me can be shared with all of you. And today I will present about unveiling novel adipose-derived stem cells exosome cosmeceutical in treating inflammatory skin disorder. As a disclosure, I'm the KOL of exosome by the Haju Medical Company in Indonesia. Since last year, exosome products have been very popular among the doctors. The use of exosome itself is widely used for the anti-aging or aesthetic medicine. However, we know exosome is far more than that. Inflammatory response provide us a basic defense against foreign antigen. However, if the inflammation is overreactive, it can lead to various diseases, including the skin inflammatory disease. The current clinical treatment for skin inflammatory disease, which we will always use antibiotic, antivirals, glucocorticoid, immunosuppressant, or even non-steroid anti-inflammatory drugs. However, they have side effect, bad medical adherence, low safety or efficacy. Therefore, small molecule drugs or microRNA are proposed to be a new novel strategies like exosome for the skin inflammatory disorder. What is exosome? Exosome is a small extracellular vesicles that play a significant roles as intercellular communications, or we know as the paracrine effect. It will transfer protein, lipids, RNA between cells from donors to recipients and influence many biological processes, including the wound healing, immune response, or inflammation. Exosome is the core component of a stem cell condition media and is processed through an endolysosomal pathway with the size of molecule around 40 to 200 nanometers. Exosome is secreted by all living cells from plant, human, or even animals, and it is secreted to all body fluid. Exosome have a very good biocompatibility, low immunogenicity, non-toxicity, non-allergenic, and also non-antigenic. Exosome, according to the International Society of Extracellular Vesicles guideline in 2018, should have a common component and also specific component. The common component is participate in the process of vesicle formation or secretion, and it's contained like a tetraspanin protein like CD9, CD63, CD81, or heat shock protein, membrane transport fusion-related protein, exosomal protein, and also small RNA. Meanwhile, the specific component closely related to the progenitor cells or donor cells. If we harvest it from antigen-presenting cells, it will express major histocompatibility type 2 and CD45, CD80 or 86, annexin 2, and HSC73. Meanwhile, if we harvest it from cancer cells. We know that cancer cells promotes angiogenesis and oncogenesis, so it will express, the exosome will express more VEGF, FGF, angiogenin, and TRNP1, also immunosuppressive protein like FAS, TRAIL, or TGF-beta. If the exosome is from mesenchymal-derived stem cells or adipose-derived stem cells, it will express more LAT7B, CD44, PDRX, TGF-beta, MER 223, MER 181, and MHC class type 2. The toxicology evaluation of human adipose-derived stem cell exosome, as you can see that the exosome should express calnexin, negative to calnexin, but positive to the tetraspanin protein like CD63, CD9, and CD81. And the exosome should absorb very well to the old cells, and it will induce the secretion of proliferation of fibroblasts and induce collagenesis and elastin deposition. And also it will inhibit the interleukin 6, 27, and interferon gamma that we know is a pro-inflammatory cytokines. As a sensitizer for the skin, compared to the hexylcinnamol proteins that indication for the skin sensitization, we know that the stimulation index of sensitization of exosome is below 1.6 and is concluded as non-allergenic. Meanwhile, as a phototoxicity test, we know that exosome protect the cells towards UV radiations better than chlorpromazine. And as a skin irritation, we know that the use of exosome also protecting the cells and do not induce skin irritation. The mechanism of action of exosome is through its ability, or it contains as anti-inflammatory angiogenesis, for proliferation and migration of the cells, and also induce the matrix remodeling. So it will very useful for the wound healing. Another therapeutic potential of exosome is already studied and proposed to be very good for antigen presenting for the tumors, or immune modulations for the immune cells, and also induce the tissue repair. However, before we use the exosome, we need to learn more about the profiling component of exosomes of exosome product that we're gonna be using. The first, the one that I could share with you guys is the exosome product that I'm use contain more than 400 kinds of lipids, 600 kinds of mRNA, and more than 1,000 growth factor or proteins that all proposed to be have an effect for anti-aging, anti-inflammatory, wound healing, anti-itching, cell proliferation, skin barrier repair, and everything is very good. The mRNA component is around more than 500, and it's mostly for the anti-inflammatory. And the lipid itself contains more than 300, and it's morely related to the ceramide biosynthesis, so it will help the skin barrier repair. Meanwhile, there are many growth factors and also cytokines, and that will propose to be very good for anti-inflammatory. The clinical experience. So the first case is I have a female 29 years old skin Fitzpatrick type 2, which is a Chinese. She presented with moderate to severe acne, as you can see, due to the use of online or over-the-counter skincare, the new skincare. So the patient was treated with BPO-based cream, and I done the comedone extraction and also injection of exosome as a skin booster for all over the face. As we can see, the progress after 2 weeks, the lesion was dry out, and then after 3 months, without any laser treatment, the PIA is getting disappear. The scar is almost not, and this is only one session. As you can see, the skin barrier is getting better. However, the patients have a birthmark. The second case is also male, 16-year-old skin Fitzpatrick type 4, and with he have a very severe acne, not only on the face but also on the neck, chest, and also back. And the patient was treated with BPO plus adapalene-based cream, comedone extraction, and then I done the exosome intradermally all over the skin. And then after 1 month, I done the fractional CO2 laser for one session with this parameter. As you can see, the lesion of acne is getting dry out, PIA is reduced, although we still found the PIA and the scars. However, the skin getting very dramatical, significant, getting better. The third case is also a female, 22 years old, skin Fitzpatrick type 4 with nodulocystic acne. The patient also complained about the pain, and I treated the patient with BPO-based cream, sunscreen, and moisturizer. However, I done the exosome intradermally combined with after the diode laser for one session. As you can see, after one session of the combination with diode laser, the lesion was dry out, and then I done the fractional CO2 laser for 2 sessions with the interval of 1 month with this kind of parameters. And you can see the acne is not only getting better, the scar is reduced, the skin quality is getting better. The pathomechanism or mechanism of action of exosome in acne is proposed through its ability to inhibit or blocking the NLRP3 inflammasome, which induced by the P-acne stimulation. By this, with this in the study showing us that it's not only lowering the expression of NLRP type 3, but also interleukin 1 beta and reactive oxygen species level in the use of exosome. Now, as we can see, this the exosome will blocking the reactive oxygen species and then also blocking the NLRP3. Thus, it will not produce interleukin 1 beta, which we know in the pathogenesis of acne. Inflammation is one of the problems in this pathogenesis. The next patient is a male, 38 years old, skin Fitzpatrick type 2 with atopic dermatitis. So patients have a very sensitive condition. However, he comes with a itchiness, a very itchiness that disturbing his sleep. The patients also have a very dry skin. As you can see, there is a scaly, ichthyotic skin, and then the patients also already being treated with a ceramide-based cream and wash, topical corticosteroid, oral methylprednisolone, or even injection of methotrexate. However, none of these treatment responded to the reduce of the itchiness or the dryness. However, after I injected the exosome intradermally for 2 sessions with interval of 2 weeks, the ichthyotic or scaly skin getting reduced and the itchiness also disappear from fast around 8 to 9 become almost zero. There are also a case report about the use of exosome in facial redness in a patient of atopic dermatitis that treating with dupilumab. As a side effect of dupilumab, the redness, the doctors using 6 sessions of exosome with interval 1 to 2 weeks using transdermal electrocorporation delivery system for 10 minutes. After 6 sessions, as we can see, the redness is getting reduced, the patient is getting better. They also review that proposed that mesenchymal-derived stem cell exosome have an immunomodulatory therapeutic and skin regeneration, wherein as anti-inflammatory and immunomodulation have been a very good potential treatment for atopic dermatitis. Exosome also being studied in vivo to the mice and CNGA mice. So the mice was induced with Biosteer AD cream for atopic dermatitis, and then the mice is treated with exosome topically. As we can see, after the treatments, the clinical scores, the level of serum IgE, the number of eosinophil mast cells, and also certain inflammatory cytokines such as interleukin 4, 23, 31, and DNF alpha getting reduced in after the use of exosome. This is the result. And it's not there's also not only anti-inflammatory cytokines reduced, but also the clinical improvement of the other mice. The exosome also induced de novo synthesis of ceramide in atopic dermatitis mice. After in the study, they found a remarkable reduce of transepidermal water loss and enhanced the hydration of stratum corneum, also reducing the inflammatory cytokines in atopic dermatitis, and also induced significantly the production of ceramide and dihydroceramide in atopic dermatitis mice. The next case is a female 50 years old skin Fitzpatrick type 2 with papulopustular rosacea that being treated as acne since years ago by the GPs. However, after we used exosome, which is the patient also treated with moisturizer and sunscreen only as a skincare, and then the exosome is injected intradermally 2 sessions with interval of 2 weeks. After 1 month, as we can see that the redness is getting reduced, the papulopustular lesion is getting dry out, and the skin quality is getting better and more hydration. The next case is a male, 63 years old, skin Fitzpatrick type 5 with chronic allergic contact dermatitis due to the rubber sandal. And the patients were already treated with topical steroid, urea-based cream. However, no significant progress for the patients. And then we done the exosome intradermally 2 sessions with interval of 2 weeks and continue the topical urea-based cream. As you can see that the most important is the itchiness disappear from fast ache to 0 within 1 week, and the chronic plaque getting thinner each treatment. The next case is a female, 13 years old, skin Fitzpatrick 4 with a prurigo nodularis that failed to the corticosteroid topical treatment, and the patients were treated with exosome intradermally 2 sessions with 2 weeks interval, and we continue the urea cream. And as we can see, the nodularization, pigmentation is getting reduced significantly. The itchiness also disappear. The last case is a male, 42 years old, skin Fitzpatrick type 4 with severe psoriasis vulgaris. So the patients have PASI 29.1, where the lesion is not only on the back, but also on the feet, hands, elbow, and scalp, and genital area. And the patients failed to the oral and topical corticosteroid treatments. However, because I'm serving secondary hospital, so I don't have any access to the biologic agents, and the patients cannot be treated with that. So we try to use exosome intradermally 1 session and continue the urea topical cream. As you can see that after 2 weeks, the plaque is getting reduced significantly, and the patient's getting more comfortable because of the itchiness also getting disappear. We know that skin inflammation is a complex response to the various disease condition or stimuli. However, the chronic inflammation is play a central role in many dermatological diseases such as psoriasis, eczema, rosacea, prurigo, and etc. The symptom of this disease can deteriorate the quality of life of the patients and impair the skin barrier, getting the patients have itchiness and disturbing the sleep, to have insomnia, and also causing social stigma over a long period. Exosome has identified as effective regulatory of immune response of the various disease condition. The mechanism of exosome in psoriasis pathogenesis, where in study they found that topical applications of exosome in the mouse model induce psoriasis with imiquimod result in significant reduce of interleukin-17 level, and also the terminal complex activation complex complement complex CD5B9 in the mouse skin. Meanwhile, the mechanism of exosome in as anti-inflammatory are proposed by 2 content. The first is MER 223, sorry, and then LED7B, where both of the component will induce the polarization from macrophage M1 to macrophage M2 and secretion of anti-inflammatory factors such as interleukin-10 and TGF-beta. That's why it will modulate the immune response better than without exosome. So, as a take-home message, we know that exosome is a nanoparticle extracellular vesicles that serve as cell-to-cell communication. It influences many biological processes, including not only wound healing but also as anti-inflammatory. The mechanism of action of exosome in acne is by blocking the NLRP3 inflammasome and reducing the secretion of interleukin-1 beta, which induced by the acne. Meanwhile, the mechanism of action of exosome in inflammatory skin disorder is by reducing the pro-inflammatory cytokine such as interleukin-4, interleukin-13, 17, 23, 31, TNF-alpha, interferon gamma, and TLSP, and also induce the production of ceramide and dihydroceramides for the skin barrier. Meanwhile, the MER 223 and LED7B contained by the exosome, inducing the macrophage M2 polymerization and leading to the secretion of anti-inflammatory cytokines such as interleukin-10 and TGF-beta. Exosome appears to be a promising candidate for the treatment of anti-inflammatory skin disorder such as acne, rosacea, atopic dermatitis, psoriasis, prurigo, or even allergic contact dermatitis. Thank you very much for your time. And if you have any question, you can contact me. Thank you.
Good evening. First, I would like to thank the authorities for inviting me to participate in the Guinea World Skin Health Day Congress. It is both an honor and pleasure to speak as the president of Society Argentina of Dermatology. The topic I will present is one that truly excites me, titled Seeing Beyond the Surface. Now I will present both esteemed medical doctors. Doctora Karina Ravera, the director, Doctora Desiree Castellanich, the coordinator of the course we are conducting this year, along with upcoming YSAT diplomator in 2025. Thank you very much.
Thank you, Dr. Alois, President of the Argentine Society of Dermatology. I will talk about high-resolution ultrasound in dermatology. Let's see beyond the surface. Okay, let's start. Ultrasound has general characteristics that we have to remember. For example, it doesn't emit ionizing radiation. We can assess our patients in real time. It's accessible and low cost. We can assess our patients with Doppler color, power ratio Doppler, and spectral Doppler. We can use artificial intelligence tools. We can assess lesions and the skin with elastography, and we can observe our images from a tablet or smartphone, for example. And the studies can be done in operating rooms, clinics, private office. That's why. And here appears the idea of focus in dermatology, where we can do ultrasound images in dermatology everywhere. We can assess our patients everywhere. Ultrasound is a not audible ultrasound. The range of megahertz come from 15 to 20 megahertz or more for assess the skin. Here we can see the spectrum of the ultrasound. But we have to understand which phenomenon occurs. First of all, ultrasound is generated inside the probe. After this ultrasound propagates through different tissue layers or lesions. After these tissue layers will give different echoes from each structure, and these echoes will return to the probe, and finally, the image appear on the screen. That's why we can name this technique echography, because we will see images from echoes from the tissue layers or lesions. Each tissue layer has a different molecular composition, thus modifying ultrasound differently, resulting in distinct images. And here in this scheme, we can observe here the probe that emits a bundle of ultrasound, and ultrasound will travel inside the tissues, inside the different layers or lesions, and every structure will give different echoes. That's why we will see different structures in the screen. These images have different grayscale, white and black. And when we see a white structure, we name it hyperechoic, or for example, in grayscale, we name it hypoechoic, or in black color, anechoic. Anechoic, for example, is water, hyaluronic acid, etc. Hypoechoic structures are muscles and fat, and hyperechoic images or structures are, for example, bone, metal from needles, cannulas, calcium, collagen, etc. But these images in grayscale, white, and black color will have different shape, localization, depth, measurements, borders, contours, artifacts. That's why we will recognize different anatomy and different lesions, for example, illnesses, etc. Let's remember these physics phenomena. 1 megahertz corresponds to 1 million of cycles per second, and 20 megahertz, for example, correspond to 20 millions of cycles per second. Frequency is inversely proportional to the depth. Therefore, the higher the frequency of the transducer or the probe, the greater the resolution we will have in superficial tissues such as the skin. That's why we will use 15, 20 or more megahertz to assess the skin. And now, which probe we will use for assess the skin? We will use linear probes with high frequency, and these probes have cable or maybe wireless. And now let's recognize an image. For example, this is a BMO grayscale image of the skin and soft tissues. And we can observe here this first line, white line, hyperechoic line that corresponds to the epidermis. Here we can observe the papillary dermis. This a little more whiter. This is the reticular dermis, and above we can observe the subcutaneous fat with these hyperechoic connective tissue lines. Here we can see the muscular fascia or deep fascia, and here the muscular structures. That's why high-resolution ultrasound in dermatology allows us recollect or collect very important data from lesions, from structures, from anatomy. For example, if we think that this is the epidermis, this is the clinical data that we can collect. With dermatoscopy, we can collect data, for example, from the superficial anatomy of the skin and the superficial dermis. But with ultrasound, we can recognize and analyze the all the lesion, all the structures, yes, we can discover a real world under the skin. And for example, this is a clinical scenario. Here is our iceberg. We can see the epidermis, we can see the clinical lesion that we can observe, touch, etc. But with ultrasound, we can analyze the limits, the depth, the contours, the measurements, the microvessels, the elastography, etc. For example, here we can see a vessel. We can observe lymph nodes from ultrasound analysis. But ultrasound of skin and soft tissues is operator dependent. We need experience and technique. And of course, we need a good technology to assess our patients. Which uses in dermatology may we have, for example, in high-resolution ultrasound? We can do diagnostic procedures, ultrasound-guided treatments, for example, injections with steroids, enzymes, antibiotics, dermal fillers, etc. We can perform ultrasound-guided biopsies. We can analyze non-tumor skin lesions, inflammatory and non-inflammatory diseases, skin tumors. We can differentiate between benign and malignant tumors. We can assess skin cancer. We can stage the cancer lesions. We can analyze preoperative marking of tumors. We can do marking of tumors. We can analyze or study skin aging and night lesions, etc. This is a very important data from this new world. And what about color Doppler? What about Doppler ultrasound? From Doppler ultrasound, we can detect blood flow. We can detect the blood flow direction, velocity of the blood flow, flow characteristics like turbulence, etc. Here, for example, in this image, we can observe the facial artery. And now, in this video, we can detect very, very clearly the labial artery and its perforance. And here we can observe this nasolabial fold from ultrasound B mode gray scale images. And here we can observe the angular artery in the nasolabial fold. And with Doppler ultrasound, we can detect the angular artery very well, and we can detect how depth it is located. In this patient, for example, before treatment, surgeries, biopsies, etc., we can analyze or study this angular artery, and it is located in the subcutaneous fat. And now we can observe that it is located 4 millimeters from the superficial, from the surface of the skin. But in this patient, we can observe a double angular artery with its blood flow, and one of them is very near of the dermis. This is a very important data before surgeries, biopsies, aesthetic procedures, etc. And now let's talk about elastography. In this lesion, we can observe a lesion located in the subcutaneous fat. It has irregularities, undefined contours, but with elastography, we can see this blue color that corresponds to a very hard lesion, and it is a malignant tumor. And now let's recognize the microanatomy of the skin. This is the normal microanatomy of the skin. This first line is a hyperechoic line coming from the epidermis. And here we can observe the papillar dermis, and this a little more whiter. This is the reticular dermis. And here in gray scale, we can observe the subcutis. And now let's talk about microvessels of the skin. In this image, we can observe this little vessel located in the reticular dermis. Yes, it measures approximately 0.2 millimeters. And here we can observe more vessels located in the reticular dermis. This is a very nice visualization of the microvessels of the reticular dermis. Very important data, for example, in tumors and in inflammatory diseases. Here we can observe the normal skin before anesthetic treatment, and in this image we can see an increase of the blood flow and of the microcirculation post-HA intradermal injection. This is a treatment of biostimulation. We can observe a real increase in microcirculation. And for example, we have a very interesting clinical scenario here. This patient received a surgery, but the anatomopathologist informed residual or remnant tumor. And from ultrasound, with ultrasound, we can observe this lesion, this hypoechoic lesion with undefined contours. And this lesion is very superficial, and the distance from the bone in the mental area is 5.5 millimeters, and the diameter of the lesion is approximately 6 by 3 millimeters of diameter. Here we can observe better this lesion, and we can observe the surface of the skin, and this is the remnant tumor. We can recognize and diagnose it very well with high-resolution ultrasound of the skin.
Hello, I'm Desiree Giselle Casternich from Buenos Aires, Argentina. First, I want to say thank you to Dr. Alois, and then to Karina Ravera for the opportunity. I'm going to speak about enzyme with EcoGI treatment. The enzymes obtained from bacteria act in catalysis of different reactions. They are substrate specific, meaning they need to bind to a specific substrate to form the enzyme substrate complex to act. For example, if adipose tissue is not present, lipase will not act. They are also temperature and pH dependent. We are discussing lipase, hyaluronidase, and collagenase. They are different from different bacteria. Hyaluronidase is an endoglycosidase that denatures the polysaccharides of the matrix. Collagenase is a metalloproteinase that breaks down collagen, and lipase degrades the triglycerides. The main indications are the scars, cellulite, localized adiposity, adverse reactions or complications from fillers, as well as sebaceous cystis, lipomas, and morphea. As I mentioned earlier, hyaluronidase is an endoglycosidase that acts as a spreading factor, clearing the way or sweeping through the space so other enzymes can penetrate and perform their function. It remodels the extracellular matrix by dissolving hyaluronic acid and chondroitin sulfate and heparan sulfate. Hyaluronidase break down the hyaluronic acid into small pieces called hyaluron, which in turn stimulates fibroblasts. Collagenase is a metalloproteinase that breaks down the fibrotic collagen, causing it lose to its connection with fibroblasts, which then begin to work for forming more ground substance, resulting in an extracellular matrix remodeling. Lipase, aided by hyaluronidase and collagenase, reaches the adipose tissue and degrades the triglycerides, causing deflation of the adipose tissue. The three enzymes work synergistically, supporting each other to achieve their effect. The contraindication includes allergy to bee, wasp, or mosquito stings, infection in the treatment area, pregnancy, breastfeeding, as well as recent vaccine. In this video, we can observe the ultrasound guide application of enzyme in the submental region, first in the preplatysmal fat and then in the postplatysmal area. Here is the result after one session. This is an article published by myself this year on the treatment of sebaceous cystis with ultrasound guide enzymes. As I always say, in medicine, results depend on the art of treatment. Enzymes provide us with a unique opportunity to combine them, and it is in this combination that our success lies. Thank you.
I'm Dr. Zach Handler, happy to be part of the Guinea World Skin Health Day Congress. Today I'm talking about the effects of air pollution on skin health. I'm Dr. Zach Handler, happy to be part. I'm a board-certified dermatologist, board-certified and fellowship-trained Mohs surgeon, cosmetic dermatologist, and clinical assistant professor at Rutgers University. Also, I'm the procedural director at New York Medical College and assistant program director. Today we're going to talk about pollution and what is pollution, different types of pollution, and how does it harm our bodies? What treatment options exist? Today we're going to talk about pollution and what is pollution is contamination of the Earth's environment with materials that interfere with human health, quality of life, or the natural functioning of the ecosystem. Pollution is contamination of the Earth's environment with materials that interfere. Free radical is a term we should discuss. That's an atom with an unpaired electron in the context of pollution. We talk about oxygen-free radicals. And no, that's not the same as an ion. An ion is not a free radical because it has a hydrogen bound to that lone electron. And when we have a collection of free radicals, we call them reactive oxygen species. Some examples you'll see in the blue, we have a stable molecule with the electrons around the outside orbit. And on the red, we see a free radical where there's a missing electron. Particulate matter, or PM, as the abbreviation goes, is generally discussed in 10 or 2.5, which is the microns or micrometers across in diameter. A human hair is 50 to 70 microns in diameter, and beach sand is 90. But dust, pollen, and mold is about PM 10, and combustible particles are PM 2.5. And we'll discuss what's it going to take for particulate matter to penetrate through the stratum corneum, which is much smaller. Say it's 0.1 micrometer in diameter. So where's the pollution? It's in the water, the air, the soil, and it may be a solid, liquid, gas, or as we call it, particulate form, most commonly in this talk. And the World Health Organization identifies 4 major air pollutants: particulate matter, ground level ozone, nitrogen dioxide, and sulfur dioxide. Could be ground level ozone, sulfur dioxide, particulate matter, cigarette smoke, polycyclic aromatic hydrocarbons, abbreviated PAH, or carbon monoxide. Could be ground level ozone. Ozone in the stratosphere is fine, protects the Earth from sun's UV rays, and although it is destroyed historically by things like CFCs or halon, which is a formerly used as a refrigerant, and other gases. Ozone at our level, below the 6 miles of the troposphere, is not so good. It's a combination of nitrogen oxide, sunlight, and carbon monoxide. It damages vegetation, harmful to inhale, and also damages skin cells. It can damage the function of the epidermis. It interacts with antioxidants like vitamin E and C, produces a reduction in the normal microflora, the microbiome percent per study. And as we'll talk about later, is that a reason we have an increase in atopic dermatitis worldwide? Ozone, in combination with UVA and cigarette smoke, will oxidize squalene to become comedogenic. We're seeing acne. And oxidation of the epidermal lipids will lead to wrinkling and aging as well. Sulfur dioxide from burning coal and oil has been on the increase in areas like Asia. In areas like Europe, there's been a slight increase, but North and South America have seen a decrease. Particulate matter has been high across West Africa, the Middle East, India, and East Asia. Particulate matter has been high across West Africa, the Middle East. But how do pollutants enter our bodies? Yes, they can be inhaled, ingested, or even via the skin, like we talked about down a hair follicle. The skin does have a natural barrier defense, but these can exceed the pollutants. But how do pollutants enter? Air pollutants do exert a harmful effect on the skin by increasing oxidative stress and overwhelming the existing skin's antioxidant defenses. Those include enzymes such as glutathione peroxidase, glutathione reductase, superoxide dismutase, and catalase, as well as non-enzymes like vitamins E, C, and glutathione. The damage from the pollutants can be from the free radicals and reactive oxygen species, which lead to DNA damage, cell damage, and aging. They also lead to inflammation. They degrade the connective tissue of the dermis, but we have the benefit of using antioxidants and understanding them enough to know that they can donate that electron to the free radical, as you see in this image to the right. Antioxidants are special as they can donate that electron and then they don't become free radicals themselves. Air pollution can induce alterations in normal function of lipids, DNA, or human skin via oxidative damage, leading to skin aging, inflammation, allergic conditions, and is associated and has been studied for conditions like contact dermatitis, especially looking at atopic dermatitis, but also psoriasis, acne, and skin cancer. Cigarette smoke contains aerosolized carbon monoxide, reactive nitrogen compounds, and reactive oxygen species / free radicals. And they reduce, because they interact with the skin and land on the skin, the vitamin C and glutathione, creating an imbalance or a reduction of the antioxidants from our body. They can lead to skin and oral cancer, obviously lung cancer as well. And they lead to wrinkling of the skin, orange skin discoloration, Favre-Raccouchot syndrome, yellow nails, and as well, polycyclic aromatic hydrocarbons are a big one we'll talk about today because they're from burning wood and car exhaust. And they're absorbed by the particulate matter that's in the environment, in the air. And this is made into a chemical that produces reactive oxygen species. So you see these PAHs are interacting and combining with the particulate matter. This leads to aging of the skin, pigment change, cancer, acne. The body skin flora, especially the micrococci, helps protect from the PAHs. And The particulate matter particles do not need to penetrate into the skin to induce skin damage, but it is possible that they do down hair follicles and pores. Particulate matter is the carrier of the PAH, and depending on the size, it may penetrate down that hair follicle. And that produces oxidative stress, leading to aging, pigmentation, and wrinkles. A study was looked at the connection between air pollutants and atopic dermatitis. It wasn't found to be causative, but those people living in areas with higher pollution had a higher severity of their atopic dermatitis. It must be a very difficult thing to study, but it has been looked at, and we'll see in the upcoming slides other findings. Carbon monoxide from fuel combustion, volcanoes, and forest fires. And a study of Taiwan stated that nitrogen oxides and carbon monoxide were associated with flexural eczema. Sulfur dioxide, which we saw in a previous chart from coal burning, is related to oxidizes sulfur, creating sulfur dioxide. And that is associated with worse atopic dermatitis in children per studies, and also stuffy noses. A study looked at East Germany in 2016, where they had a high amount of sulfur dioxide, and compared it to West Germany, which had lower. And they found that there is a higher rate of atopic dermatitis in East Germany, where there is a greater amount of sulfur dioxide. But what do patients really want? They're certainly becoming aware, but they're looking to apply something simple. They don't want a complex regimen. Once a day is sufficient for them. They want something that goes on smoothly as a leave-on and isn't irritating or burdensome to apply. We can encourage them to wear sunscreens that have broad spectrum uh, protection against UVA, avoid cigarette smoke, and use topical antioxidants with their sunscreen. Some products already have it integrated. Also using air purifiers and using a mask if exposed to occupational hazards outdoors. And we really want to block pH from damaging the cells, so covering up the arms and legs in areas that would normally be exposed. Use of antioxidants, as we've discussed, is really important because antioxidants reduce the free radicals that can damage the skin. Use of antioxidants. Topical antioxidants are numerous: vitamin C, vitamin E, flavonoids, lutein, coenzyme Q10, resveratrol are just some examples. Algae is another one, lycopodium. Topical air purifiers, they reduce the particulate matter in our proximal environment and also reduces asthma attacks. And it's been used in the operating room and hopefully reduces infections as well. Personal protection, like we discussed, protect the eyes with UV filter sunglasses, wear a mask to minimize inhalation of particulate matter, and then covering the skin, minimize the exposure to PAHs that are bound to particulate matter, creating reactive oxygen species. Reduction
There's
of
ways to
polycyclic aromatic
indirectly
hydrocarbons
study the
amount of
from
PAH
being taken into the
done
cell. There's a number of products out there so they can
a
prevent
bench
the
study
binding
by
of these
measuring the
PAHs to the receptors.
CYP1A1.
It's hard to directly
We
measure.
can't
It's currently
directly
not possible
measure the
to
receptor, the
measure
AH
the
receptor,
amount of
but we can
uptake,
measure
but we can
CYP1A1.
look for
And that's why we know these
inflammatory
products work.
markers like CYP1A1,
There's ways to
which can
indirectly
be a
study
substitute for
the amount
directly
of
measuring
pH done
the polycyclic aromatic hydrocarbons
a
on the
bench
skin.
study
And so that
by
can be tested
measuring the
clinically.
CYP1A1.
Well, that can be tested in a lab, but
We
it's
can't
something that could
directly
be monitored
measure
without
the
being very
receptor, the
invasive of a
AH.
study.
Show you in a second. There's a couple
There's a couple
products
products
out
out
there
there
that can
that
reduce the
can
amount of
be
inflammation.
integrated into a
We're
topical
showing that it's
compounded
not being taken up by the
product.
skin, it's not
I
binding
have no
to
conflict
the
of interest
AH
with this
receptor,
company,
and
but
therefore
there's a couple out there that
we don't have as much
claim
inflammation.
to
reduce
And those
the
products that
amount of
we see
pollutants if they
here,
were
which
to
I have
land on
no
the skin.
conflict of interest with,
There's a
can
couple
be
of products out
applied
there
and used in
that
topical
can be
lotions
integrated
and
into a
balms.
for
Future
future
products will
products. I think
probably
a lot of lead
contain
facial
these.
lotions are going to have some sort of
Future products will
receptor
probably
blocker,
contain
like the previous slide gave two examples of. And I think
future
those are
products will probably
products for leave-on
contain
that are
these.
going to work really well in conjunction with
Future products
UV
will probably
blocking like sunscreen
contain these.
and topical antioxidants like
Future
like
products will
vitamins D
probably
and E.
existing products
Currently,
do help. That
products
includes
do
soap, body wash that
exist that will
removes those
help,
particulate
such
matters
as
from the skin.
traditional
Other products
soap
are making
and shower
anti-pollution
gel
claims
that
as
removes
well,
the
such
dirt
as those with
and the
carbon
pollution
in
from the
them
skin.
or presence
Also, other
of
products out there claiming anti-pollution
bisabolol or a
technology by
ginger
having
root
carbon in them,
extract.
and then extracts
Existing products do
that are
help. That
demonstrated to
includes
have some
soap, body
benefit
wash
as
that
well.
removes those particulate matters from the
Bisabolol
skin.
and ginger
Other
root
products are making
extract.
Also, we have
Also, there's
lotions that can be
cleansers.
applied
In
and they
addition
can
to
have
cleansers,
antioxidants in them,
leave-on
and they
lotions,
can
like I
prevent free
mentioned, can have
radicals
antioxidants in it,
from
like
creating damage.
vitamin C and
Also,
E.
broad spectrum
And then broad
SPF,
spectrum
which may
SPF,
include
you want to
ingredients
block
such as
that UVA.
antioxidants like vitamin C or E,
And they
but
can have
also
additional ingredients like
antioxidants
antioxidants
as
as
well.
well,
Also, we
or
have lotions
like
that can be
ginger
applied
root.
and they can have.
I think I
overall,
appreciate your
as
time
everyone
and
listened, there's
listening,
a lot
and
of
thank you.
potential, and
And
I hope you
hopefully
enjoyed
everyone learned
this.
something.
I think overall,
I appreciate your
there's a lot of
time and
potential,
listening, and
and
thank
I
you.
hope you enjoyed
And
this.
hopefully everyone learned something.
I think overall.
Mesdames et messieurs, bonjour. Je suis le professeur Samira Zoubiri. Je suis dermatologue, chef de service de dermatologie à l'hôpital Mustapha Alger Centre en Algérie. Et je suis très honorée de participer à ce congrès du Guinea World Skin Health Day. Pour ma participation à cet événement, j'ai choisi le thème vitamine D et peau entre réalité et controverse. Pour illustrer l'importance accordée dans la littérature à ce thème, regardez le nombre de publications qui n'a cessé d'augmenter depuis les années 90. Nous avons souvent été confrontés à ce type de situation où des patients viennent nous demander de leur prescrire systématiquement un dosage de la vitamine D sans signe d'appel particulier. Une autre situation où nos patients nous demandent de leur prescrire de la vitamine D parce qu'après tout, ça ne peut que leur faire du bien, parce qu'ils se sentent fatigués et parce que c'est... En effet, cette vitamine a la réputation d'être la substance bonne à tout faire. Elle a un rôle dans le bien-être, dans la longévité. Elle a un rôle de prévention des cancers, un rôle dans le diabète, dans les maladies cardiovasculaires et, ce qui nous intéresse nous, même un rôle dans certaines pathologies dermatologiques. Entre mythe et réalité, qu'est-ce qu'il en est? La réalité, et ce qui est connu depuis longtemps, c'est que la vitamine D a un rôle dans la croissance et dans la minéralisation osseuse. Son rôle est certain dans l'homéostasie phosphocalcique. Notre vitamine D, quelle est son origine? Quel est son parcours et son métabolisme dans le corps humain? Et quelles sont surtout ses actions? D'où provient notre vitamine D? Il y a deux sources de vitamine D, la source endogène et la source exogène. La source endogène est la plus importante. C'est en fait la synthèse au niveau de la peau, sous l'action des ultraviolets, de la vitamine. Et cette production endogène, on le comprend aisément, va dépendre de l'importance de l'ensoleillement, de la latitude, de la saison. Elle dépend également des habitudes sociales et vestimentaires, ainsi que de l'âge et du phototype. Ici, sur ce graphe, on voit les variations du taux sanguin de vitamine D en fonction des mois de l'année. Et on voit bien que durant le mois d'août où l'ensoleillement est plus important, ce sont les taux les plus élevés comparativement aux taux bas du mois de novembre et du mois de février. La source exogène de la vitamine D, c'est l'alimentation. Ici, sur ce tableau, voici une liste de l'ensemble des aliments les plus riches en vitamine D. Nous avons par exemple le saumon frais sauvage. Nous avons également le saumon en conserve, le lait aussi, les produits laitiers, le beurre, qui sont des aliments riches en vitamines. Et le métabolisme de la vitamine D. Eh bien, la vitamine D va subir une première hydroxylation hépatique pour donner la 25-hydroxyvitamine D, puis une deuxième hydroxylation au niveau rénal pour donner la 1,25-hydroxyvitamine D ou calcitriol, qui représente en fait la forme active de la vitamine. Ce schéma résume l'ensemble des sources et du métabolisme de la vitamine D, deux principales sources. La source endogène au niveau cutané, sous l'effet des UV, la peau va fabriquer de la vitamine D. Une source exogène provenant de l'alimentation. Cette vitamine D va aller au niveau du foie, subir une première hydroxylation, puis au niveau du rein, une deuxième hydroxylation pour donner la forme active qui va être responsable des différentes actions métaboliques. Le taux sérique de la vitamine D, en fait, c'est le taux en 25-hydroxyvitamine D qui représente le statut vitaminique d'un individu. Quelles sont les actions de la vitamine D? On lui connaît des effets osseux et des effets extra-osseux. Les effets osseux, c'est principalement la minéralisation osseuse. Les effets extra-osseux, c'est une action au niveau intestinal pour stimuler l'absorption du calcium, une action sur le système immunitaire puisque la vitamine D stimule l'immunité innée, stimule l'expression des toll-like récepteurs 1 et 2 et de ce fait a une action anti-infectieuse. La vitamine D a également un effet antiprolifératif, c'est pour ça qu'on lui connaît un effet préventif, notamment dans le cancer du côlon. Sur cette planche, on voit les différents mécanismes d'action de la vitamine D sur le système immunitaire avec l'immunomodulation et ses actions anti-infectieuses, sur le pancréas avec ce contrôle glycémique et sur la prolifération cellulaire avec cet effet préventif du cancer du côlon et du cancer de la prostate. Quels sont maintenant les effets extra-osseux de la vitamine D? Cutanée principalement, c'est ce qui nous intéresse, c'est la régulation de la prolifération et de la différenciation des kératinocytes. On connaît de nombreuses pathologies où il y a des troubles de la régulation, de la prolifération et de la différenciation des kératinocytes, notamment le psoriasis. La vitamine D a un effet immunomodulateur sur les kératinocytes, elle diminue les TH17 et elle a un rôle dans la régulation du cycle pilaire. Ces effets cutanés sont également un type de réparation des dommages UV induits, des effets antioxydants, ainsi qu'une diminution du stress oxydatif après exposition solaire, et donc, d'après ces effets, c'est un effet anti-âge, anti-vieillissement. Les effets cutanés, si on peut les résumer, c'est une inhibition de la prolifération kératinocytaire, c'est une stimulation de la différenciation des kératinocytes et l'induction d'une apoptose. Donc, une restauration de la barrière cutanée. Ici, un effet de restauration de la barrière cutanée, elle a un effet dans toutes les pathologies où il y a anomalie de la barrière cutanée, anomalie de la prolifération des kératinocytes, comme c'est le cas par exemple du psoriasis, de la dermatite atopique et de l'ichthyose. Concernant le psoriasis, le rôle des analogues de la vitamine D dans le psoriasis est connu. Nous prescrivons à nos patients psoriasiques des topiques à base de la vitamine D depuis cette observation initiale publiée en 1986 qui a rapporté une amélioration des lésions de psoriasis chez des patients traités par vitamine D pour ostéoporose. On aura compris, de par son mécanisme sur la différenciation et la prolifération kératinocytaire, le rôle de la vitamine D dans le psoriasis. Dans la dermatite atopique maintenant, il y a des études qui ont retrouvé en fait une corrélation entre le taux de vitamine D et la sévérité de la dermatite. Cette étude a retrouvé, on revoit dans le groupe sévère, c'est les taux les plus bas de vitamine D, alors que dans le groupe à gauche, légère à modéré, nous avons des taux moins effondrés de vitamine D. Sur cette courbe, on voit la corrélation scorade vitamine D, déficience en vitamine D, corrélation négative entre le scorade et le taux de vitamine D. Alors, que penser de cette corrélation entre la sévérité de la dermatite atopique et le déficit en vitamine D? En fait, il existe d'autres facteurs de confusion, d'autres facteurs qui peuvent expliquer la sévérité d'une dermatite atopique, notamment la saison. On sait bien que le plus souvent, les dermatites atopiques s'améliorent l'été et s'aggravent l'hiver. La sévérité de la dermatite atopique dépend des zones géographiques. Elle dépend des endotypes phénotypes, de la génétique, elle dépend des traitements déjà reçus, de l'observance thérapeutique, de l'existence d'irritants, d'allergènes et des surinfections cutanées. Donc tous ces facteurs contribuent à la sévérité de la dermatite atopique et il est difficile de dire que la vitamine D est la cause de la dermatite atopique. Cet article qui a émis des recommandations chez les patients atteints de dermatite atopique, en fait, c'est les patients qui ont des dermatites atopiques difficiles à traiter, qui auraient un risque plus élevé d'avoir un déficit en vitamine D et chez lesquels le dosage est recommandé. Donc si c'est un patient qui a une dermatite atopique qui ne répond pas, malgré une bonne éducation thérapeutique, malgré le fait d'une bonne observance du traitement, là, on est en droit de se poser la question par rapport au déficit en vitamines. Maintenant, quel est son rôle? Ces publications du British et du NEJM sur des observations de l'utilisation de topiques à base de vitamine D pour les ichtyoses génitales, en fait, c'est pour les ichtyoses hyperprolifératives du fait du mode d'action sur la prolifération kératinocytaire, et ces dérivés de la vitamine D dans l'ichtyose ont un rôle de diminution et non d'élimination de l'érythème et de la desquamation. Et bien sûr, les topiques à base de vitamine D sont totalement inefficaces dans les ichtyoses bulleuses et les formes liées à X où le mécanisme n'est pas en rapport avec une hyperprolifération kératinocytaire. Et les recommandations en ce qui concerne l'ichtyose pour supplémenter en vitamine D sont de niveau 3 avec un grade C. Il n'est pas recommandé de supplémenter systématiquement les ichtyoses hyperprolifératives. Cet article qui a évalué 7 nouveau-nés qui avaient une ichtyose congénitale avec un déficit avéré en vitamine D. Sur le plan biologique, ils avaient tous un déficit en vitamine D. Ils ont eu une supplémentation de 10 jours. Et les résultats ont été les suivants, comme vous le voyez sur cette iconographie. Sur la bande du haut, donc ce nouveau-né qui a vu une amélioration des lésions du visage. Sur les photos du bas, on voit bien ce bébé avec une amélioration des lésions du visage et du tronc. À côté de ces pathologies, autres dermatoses, on voit bien que il y a eu un engouement pour les dosages biologiques de la vitamine D avec une explosion du nombre de dosages de la vitamine D. À tel point que cet article se pose la question, est-ce qu'il y a réellement une pandémie du déficit en vitamine D, puisque 35 à 70% des Européens ont des taux de 25-hydroxyvitamine D insuffisants selon certains auteurs. Pour cela, il faut d'abord définir ce que c'est qu'un vrai déficit en vitamine D, savoir quelle forme métabolique on doit doser et quelle technique de laboratoire est la plus fiable pour l'interprétation. Le déficit est défini par des taux inférieurs à 20 nanogrammes par millilitre, c'est le taux le plus bas, et les taux entre 20 et 30 sont considérés comme insuffisants. Les valeurs seuil, l'objectif souhaitable, c'est d'avoir des taux supérieurs ou égaux à 30 nanogrammes par millilitre. Au-delà, c'est satisfaisant. Au-dessous, on est dans le déficit qui peut être modéré ou sévère. Donc vous le voyez ici, les chiffres, ces chiffres-là, inférieurs à 30, c'est considéré comme insuffisant. Quelle forme métabolique dosée? On en a parlé précédemment. En fait, le métabolite hépatique, la 25 vitamine D, qui doit être dosée. La technique de laboratoire utilisée, la technique de référence est la chromatographie liquide couplée à la spectrométrie de masse, car les dosages immunologiques sont moins fiables. Sur ce graphe, on voit bien la variation du taux de vitamine D en fonction de la technique de laboratoire utilisée. Pour certains laboratoires, on est dans le déficit, alors que pour d'autres, on est dans des valeurs normales pour le même échantillon qui diffère selon la technique de laboratoire. De plus, en plus de la technique de laboratoire, un taux de vitamine D doit être interprété en fonction d'autres facteurs qui peuvent l'influencer. Ces facteurs sont l'exposition solaire, le tabagisme, l'obésité, le phototype. Les sujets âgés, ils ont tendance à avoir des taux plus bas de vitamine D, ils ont tendance à avoir un déficit. L'institutionnalisation, c'est les sujets qui vivent dans une institution et qui ne sont pas suffisamment exposés au soleil. Les traitements associés, certains traitements sont connus pour s'accompagner d'un déficit en vitamine D, notamment ce que nous utilisons très souvent et au long cours pour nos patients, les corticostéroïdes péros. L'ostéoporose, bien sûr, les insuffisances rénales, l'insuffisance hépatique, les maladies inflammatoires du tube digestif et la maladie cœliaque de par la malabsorption intestinale. Donc, la concentration sérique de la vitamine D d'un individu dépend de sa génétique, de son âge, les sujets âgés auront plus tendance à faire un déficit, de son indice de masse corporelle, les sujets obèses font un déficit plus que les autres, ça dépend du mode de vie, de l'alimentation, du tabac, des activités extérieures, et ça dépend aussi de la zone géographique, du climat, de la latitude et de la saison. Les pathologies dermatologiques, en fait, dans la pelade, dans le vitiligo, dans le lupus par exemple, ou dans la maladie de Verneuil, plusieurs publications ont retrouvé des taux de vitamine D bas au cours de ces affections par rapport au sujet contrôle, et il existait une corrélation négative entre le taux de vitamine D et la sévérité de la maladie. Sur ce tableau, on voit bien l'ensemble des dermatoses qui sont associées à un déficit en vitamine D, le psoriasis, la dermatite atopique, les ichtyoses, l'acné, l'hydradénite suppurative, le vitiligo, le lupus et même la pelade. Mais en fait, l'association d'un déficit en vitamine D à une dermatose ne signifie pas que ce déficit est la cause de la dermatose, car l'ensemble de ces observations qui ont rapporté ces associations sont des études d'observation. Et le niveau de recommandation pour supplémenter en vitamine D au cours de ces dermatoses, comme vous le voyez sur ce tableau, il n'y a aucun grade de recommandation A. L'ensemble des grades de recommandation sont B ou C avec des niveaux 2 et 3. Par exemple, chez cette patiente acnéique âgée de 24 ans, qui n'a pas d'antécédent particulier et qui vient consulter pour une acné inflammatoire, c'est justifié de doser la vitamine D chez elle. En fait, le rôle de la vitamine D a été évoqué à travers des études dans l'acné, de par sa relation indirecte pour la réduction de la synthèse de l'interleukine 6 et de l'interleukine 8, mais il n'est pas recommandé de doser systématiquement la vitamine D. Par contre, si cette même patiente a une maladie cœliaque et qu'elle a des douleurs osseuses, donc elle a déjà la maladie cœliaque qui est un facteur à prendre en considération quand on interprète un taux de vitamine D. De plus, elle a un signe d'appel, douleur osseuse. Donc là, c'est justifié de doser la vitamine D. Par exemple, ces deux patients psoriasiques, le patient de gauche qui a un psoriasis du dos des mains, qui a un BMI correct, qui n'a aucun signe d'appel ostéo-articulaire, et le patient de droite qui a, en plus de son psoriasis, un BMI à 33 et une maladie de Crohn. Il est clair que c'est le patient de droite, le patient avec un BMI élevé, avec une maladie inflammatoire du tube digestif, qu'il faudra doser en vitamine D. En oncologie aussi, on parle du rôle de la vitamine D, notamment dans le mélanome, où des études ont retrouvé une relation entre le taux de vitamine D et la survie du mélanome. Mais en fait, d'autres études sont venues par la suite. Il y avait une contradiction en fait entre ce taux de vitamine D et mélanome. 3758 patients, et il n'y avait pas de corrélation entre la survie des patients et le polymorphisme nucléosidique des récepteurs de vitamine D. Les résultats sont contradictoires et bien sûr, d'autres études sont nécessaires pour faire le point. Donc, si on peut se résumer par rapport au rôle de la vitamine D dans certaines dermatoses, on doit d'abord confirmer qu'il y a un déficit. On doit interpréter les résultats en fonction d'autres facteurs, pas uniquement de la dermatose, mais de tous les facteurs qui peuvent s'associer à un déficit de vitamine D, comme par exemple l'âge du sujet, les autres traitements qu'il prend. Et il est clair dans la littérature qu'il y a une association d'un déficit de la vitamine D à certaines pathologies cutanées. Maintenant, quel est le lien entre ce déficit et la pathologie reste à définir. Vitamine D, qui dépister, qui supplémenter? Il faudra dépister les personnes à risque. Il faut chercher d'abord des signes cliniques d'un déficit en vitamine D, qui sont les douleurs osseuses localisées ou généralisées, la faiblesse musculaire, la marche ralentie ou une démarche dandinale. Et il n'est pas recommandé de faire un dépistage systématique de la vitamine D, en vitamine D dans la population, mais les personnes à risque sont les personnes âgées, les personnes vivant en institution, les sujets obèses, les insuffisances rénales chroniques, l'ostéoporose, certains médicaments comme les corticoïdes. Je vous rappelle que la Haute Autorité de Santé a émis des recommandations quant à l'utilité clinique du dosage de la vitamine D et qui rejoint ce que je viens de dire. De plus, le coût économique de cette vitamine D, du dosage sanguin s'il n'est pas justifié et de la supplémentation si elle n'est pas justifiée. Regardez cette courbe qui montre que cette vitamine D, ces examens biologiques ont représenté la plus forte contribution à la croissance des actes de biologie médicale entre 2008 et 2009. Pour se résumer, supplémenter en cas de déficit et par voie orale parce qu'elle assure une bonne biodisponibilité. On supplémente les personnes âgées de plus de 75 ans. On supplémente s'il y a un déficit avéré. On supplémente en cas de prise médicamenteuse type corticoïde au long cours. Et on supplémente en cas d'ostéoporose. On connaît le risque fracturaire associé à la corticothérapie, ce qui justifie supplémentation systématique. Attention à la supplémentation, elle peut être toxique. Cette observation a rapporté une hypercalcémie sur intoxication à la vitamine D. Donc il ne faut pas banaliser ce traitement par la vitamine D, mais il faut au contraire une utilisation rationnelle. Pour terminer, la vitamine D a un rôle physiologique évident. D'autres utilités cliniques sont plus hypothétiques, nécessitant d'autres études. S'il y a un déficit avéré, la supplémentation peut améliorer certaines pathologies dermatologiques. Le dépistage systématique n'est pas recommandé, ainsi que la supplémentation systématique qui n'est pas recommandée, mais qui est justifiée selon les données cliniques et le terrain. Pour terminer, la vitamine D continue à susciter encore beaucoup d'effervescence et elle n'a pas encore dit son dernier mot. Je vous remercie pour votre attention.
Dear colleagues, good morning. My name is Caterina Pazzazzi. I'm a professor of dermatology from the Aristotle University School of Medicine in Thessaloniki, Greece. I would like to thank the organizers for their kind invitation to deliver this talk on the clinical presentation, pathophysiology, and diagnosis of bullous pemphigoid. These are my disclosures. To begin with the disease, bullous pemphigoid is by far the most common autoimmune bullous disorder. The annual incidence of bullous pemphigoid is worldwide increasing, ranging from 13 to 42 patients per million inhabitants per year. BP mainly affects elderly patients, and the risk increases up to 300-fold above the age of 90. It's a typical example of autoantibody-mediated organ-specific autoimmune disorder. In this disease, many triggering factors induce the formation of circulating and tissue-bound autoantibodies, which target adhesion structures of the skin and mucous membranes. There are associated diseases in patients with bullous pemphigoid, most commonly neurodegenerative diseases and psoriasis. And also there are associated medications such as gliptins and anti-PD-1 immunotherapy. Other triggering factors reported in the literature are exposure to UVA, mechanical, thermal, or chemical injury. In the spectrum of pemphigoid diseases, there are many clinically and immunopathologically distinct entities depending on the target proteins. So, bullous pemphigoid, which is the most common in the spectrum of pemphigoid diseases, is caused mainly by BP180 and C68 domain autoantibodies and BP230 autoantibodies. And a few words about the target antigens in bullous pemphigoid. To begin with BP180, the non-collagenous 16A domain of this antigen represents the immunodominant region, which contains the major epitopes recognized by autoreactive T and B cells. The NC60A specific peripheral T cell response in bullous pemphigoid is of a mixed T helper 1, T helper 2 type with T helper 2 predominance, and this is a knowledge very, very crucial for the new therapies. A subgroup of patients, though, in bullous pemphigoid reacts with different BP180 extracellular epitopes, but not with the NC60A domain. BP230, on the other hand, is an intracellular protein which belongs to the titin protein family. The pathogenic role of BP230 autoantibodies remains controversial. BP230 autoantibodies may be associated with some atypical forms of bullous pemphigoid, such as the prurigoform, eczematous, or urticaria manifestations, and the localized type of bullous pemphigoid. The etiology underlying the autoimmunity to basement membrane zone antigens in bullous pemphigoid remains unclear. The breakdown of self-tolerance is mainly caused by regulatory T cells. There is an epitope spreading, and this is a phenomenon in which the target of cellular and humoral immune responses gradually expands from the initial dominant epitope to other epitopes on the same protein or to other proteins in the same tissue. Mainly in most of BP cases, there is complement activation by the autoantibodies bound to the basement membrane zone. There is a recruitment of granulocytes, and after the mast cell degranulation, the neutrophils attracted to the basement membrane zone become activated, and then they release tissue-destructive enzymes, including neutrophil elastase and matrix metoproteinase 9. Also, autoantibodies in bullous pemphigoid cause internalization of BP180 from basal cell membranes, reducing keratinocyte adhesion to the basement membrane. And keratinocytes also secrete interleukin 6 and 8 cytokines after binding to BP autoantibodies, potentially attracting also neutrophils and eosinophils independent of the complement system. So, the antibody antigen binding activates simultaneously different molecular pathways rather than a single cascade. The mechanism of blister formation in bullous pemphigoid is complex, but the role of type 2 inflammation is very important. There is also a balance of contribution between complement-dependent and complement-independent mechanisms. Can this may in part explain the clinical diversity in bullous pemphigoid? And this, from a recent article, is a scheme very well depicting the complex pathomechanism of bullous pemphigoid with the complement-independent mechanism and the IgG1 complement dependent cascade, in which we can also see the role of neutrophils, the role of mast cells, the role of tough helper 2 inflammation, and also partially the role of IgE. Clinically, bullous pemphigoid in its typical forms present with erythema, pruritus, and tense bullae. The pruritus is intense, the blisters are tense on the skin in the typical form, and with disease progression, these tense blisters can persist for several days before they rupture, resulting to crusts and erosions. Mucous membranes are affected in 10 to 20% of patients, with mostly only mild oral lesions in most bullous pemphigoid patients. There is also an early pre-bullous stage, which may present with solely pruritus, eczematous, or urticarial lesions. That's why there is clinical spectrum for bullous pemphigoid. This is a statement very well characterizing the disease. The clinical manifestations of bullous pemphigoid are protean and may mimic a variety of other inflammatory dermatoses. So we should differentiate bullous pemphigoid from dermatitis, drug reactions, scabies, cirrhosis, or pruritus due to renal or liver impairment. A significant percentage of patients with bullous pemphigoid, up to 20%, have no obvious bullae. So this is a typical example of a patient scratching herself with erythema, pruritus, dry skin, but no bullae, and this is a case of non-bullous pemphigoid. In cutaneous pemphigoid, the non-bullous pemphigoid form is well described in many of the textbooks dedicated to blistering disorders. A dermatologist should consider bullous pemphigoid when an elderly patient comes with unexplained itch without evident skin manifestations, or when an elderly patient does not respond well to return therapy and has persistent itch with recurrent eczematous lesions. And to proceed with the diagnostic procedures, on histology from a lesion of bullous pemphigoid, a recent lesion of bullous pemphigoid, we will see eosinophilic spongiosis, detachment of the epidermis and a subepidermal cavity in which we can find numerous eosinophils within the cleavage. A superficial also inflammatory cell infiltrate within the dermis may be found, characterized by varying degrees of intensity and consisting of lymphocytes, eosinophils, and neutrophils. But histopathology by itself, only by itself, cannot differentiate among various pemphigoid disorders. We should proceed with direct immunofluorescence from perilesional skin, or in case of non-bullous pemphigoid, from the lesional area. PP antigens are located at the dermal epidermal junction, resulting in typical linear binding of IgG, IgA, and or C3, and rarely IgE or IgM at the basement membrane zone. Serration pattern analysis is a very helpful technique. This is performed on thin sections of perilesional skin biopsies using a conventional immunofluorescence microscope. In bullous pemphigoid, an N-serrated pattern with arches closed at the top is observed, while in epidermolysis bullosa acquisita, the immunoreactants demonstrate a growing grass or upstanding arm pattern with the arches closed at the bottom, forming a U shape, which is termed a U-serrated pattern. And in this initial paper, you can see which entities are differentiated by the use of N and U serrated pattern. The ulcerated pattern on the epidermal side is commonly seen in bullous pemphigoid, while the ulcerated pattern in EVA. Indirect immunofluorescence is performed using a monkey esophagus or normal human skin as a substrate, and we can see the typical linear and the basement membrane zone reactivity. The use of human salt split skin, as you can see here, allows the differentiation of pemphigoid autoantibodies in those who binds to the epidermal part of the blister or to the dermal part of the blister. And when we see it on the epidermal part, it's usually VP180 and VP230, and we have bullous pemphigoid. The ELISAs, the enzyme-linked immunosorbent assays, are very useful techniques to detect the circulating autoantibodies. ELISA is based on the immunodominant parts of the recombinant antigens. It's widely available for the detection of circulating IgG against BP180 and C69 and BP230. BP180 and C68 correlate with disease activity in most patients with bullous pemphigoid. Also, evaluations of serum autoantibody levels are recommended for the follow-up of patients. And lately, multivariant ELISAs have been introduced to enable a parallel identification of different autoantibodies on a single ELISA plate. There are also biochips. Biochips are miniature substrates that can be assembled together in a mosaic in a single incubation field of a laboratory slide. And with this approach, we can simultaneously test multiple autoantibodies against several antigens in a time and serum-saving manner. To summarize, for bullous pemphigoid diagnosis, we have the clinical picture with blisters and erosions or urticarial plaques and erythema predominantly at the skin. Subepidermal blisters with eosinophilic, lymphocytic, or neutrophilic infiltrates in histology. Linear deposits of IgG and complement indirect immunofluorescence of the perilesional skin. Blister roof staining on salt split skin by indirect immunofluorescence, and detection of BP180 and BP230 autoantibodies by ELISA. And for assessing or evaluating the severity of BP, we have also this tool, bullous pemphigoid disease area index. And there are studies in which we have also defined how to recognize mild, moderate, or severe diseases, bullous disease. When it's less than 20, it's mild. When it's more than 20 and less than 57, it's moderate. And when it's more than 57, it's severe disease. So, to sum up, bullous pemphigoid is the most common autoimmune blistering disorder in the elderly. BP180 and C16A is the most common target antigen. The pathogenesis of this disease is multifactorial with a very important role of TAF helper 2 inflammation. There are bullous forms and non-bullous forms of bullous pemphigoid. Diagnosis is based on clinical picture, direct immunofluorescence, and serological tests, and the treatment horizons are based on the cytokines involved in BP pathogenesis. And with this, I would like to thank you for your attention, and I'm ready to take your questions. Thank you.
Dear organizers and dear participants, I would like to express my heartfelt thanks to the organizers of this Global Congress. Your passion and dedication are truly appreciated. It's an honor to participate here. My name is Pille Konno. I am dermatovenerologist from Estonia. As doctors, we are like detectives, gathering evidence to confirm our diagnosis. Ultraviolet-induced fluorescence dermoscopy opens a new dimension in dermatology, allowing for more precise and early diagnosis of various skin conditions. Today, I represent the Estonian Society of Dermatovenerologists, the president, I take great honor in being a volunteer in various organizations. I have no conflicts of interest to declare. We all know the Woods lump, but where does its name come from? It is named after Professor Robert William Wood, an American physicist who invented this device. The Woods lamp uses ultraviolet light to examine the skin, revealing conditions that aren't visible under normal light. Wood's lamp is a diagnostic tool in dermatology. Unfortunately, this useful tool is forgotten in a hurry. Passion is to create something new. The dermoscopy device is now integrated with UV light source 365 nanometers along with 10-fold magnification. To use a UV device, the room must be completely dark. It's hard to believe, but darkness reveals the unseen. A black light, also called a UVA light, it is this part of the electromagnetic spectrum with a peak wavelength of 365 nanometers. Let's talk about the physics of fluorescence. To understand how it works, it's necessary to take a closer look what happens at the molecular level. UVA light shines on certain substances called phosphors. Phosphors essentially convert invisible UV light into visible light. Skin contains natural phosphors such as collagen and elastin. Elastin contains several phosphors like a 3-carboxylic amino acid with pyridinium ring, and the main phosphor in collagen is tyrosine, an amino acid. The Stokes shift is a difference in energy or wavelength between the absorption and emission of light by a molecule. How it works? Absorption. When a molecule absorbs light, it gets excited and moves to a high energy state. Emission. After a short time, the molecule relaxes back to a low energy state and it releases light. The emitted light is what we see as fluorescence. It is usually visible light, and the color depends on the energy difference between the excited state and the ground state. Why is it important? This method helps dermatologists identify conditions like fungal infections, pigmentary disorders, and even early signs of skin cancer that might not be visible under normal light. Let's start from white fluorescence. White color might be keratin or lack of melanin. Take a look. Is it easy or challenging? Is it pigmental lesion or not? UV helps us a lot. Now I'm 100% confident that it is keratin. This is not nevus, this is seborrhoic keratosis. Here is a lesion on dark skin. You can see white keratin. It is seborrhoic keratosis. Again, seborrhoic keratosis, completely benign lesion. Look how beautiful keratin appears under UV dermoscopy. Here is irritated septae, and on the right side you can see something more. Lichen planus-like keratosis, also known as lichenoid keratosis, is benign lesion. It is believed to be a seborrhoic keratosis that's undergoing regression. And you can see dermatoscopic criteria like regression structures, focal gray dots. Next patient, a pregnant patient, decided to decorate her stomach with a henna tattoo and noticed a lesion. Keratin absorbs more henna, and therefore the lesion became darker. But with UV, you can see the white keratin again. That confirms it's a benign sepgay. You can see again white keratin. This patient was disturbed by sun intolerance, burning, and skin redness. But the skin looks completely normal. What's your diagnosis? Here you can see well demarcated white depigmentation. It is vitiligo. It is very easy to detect vitiligo by UV, and you can see even repigmentation. UV also allows early recognition of surgical grafts repigmentation after transplantation. In the case of tattoos, it is difficult to understand where is a vitiligo and where is the artificial pigment. Some tattoo pigments can freeze, especially orange. In summary, UV helps detect vitiligo, melasma, and other pigmented lesions. We can detect different infections also. Certain bacteria of the skin freeze with the use of UV. For example, Corynebacterium tenuis, which cause trichomycosis axillaris. We can see yellow-green and dermoscopy revealed cotton-like structures on the hair shafts. Pseudomonas aeruginosa secretes green pyoverdine. Sometimes an antifungal treatment is used very easily for a rash in the fold area. Clinically, however, other diseases must also be taken into account, like intertrigo psoriasis. But here is very easy. Under UV, you can see orange color. Corynebacterium minutissimum produces coproporphyrin 3, a coral red color. Other causes of intertrigo will not flourish similarly. Clinically, erythrasma can mimic different intertriginous dermatoses, such as inverse psoriasis or candidiasis, and sometimes making diagnosis difficult, but by UV it's very, very easy. It is not contact allergic reaction, it's erythrasma again. Coral red color under Wood's lamp, and the same coral red color under UV dermoscopy. Here as an example, erythrasma on dark skin too. Symptoms, it typically doesn't cause pain or itching. Some people may experience mild discomfort or a slight burning sensation. Corynebacteria, specifically Corynebacterium minutissimum, cause erythrasma, a benign skin infection that often presents reddish-brown patches, primarily in skin folds. Is typically treated with topical antibiotics such as clindamycin or erythromycin. Orange color. It is erythrasma. Are you sure? Yes, it's erythrasma, but we can see yellow-green and dermoscopy revealed cotton-like structures on the hair shafts. Here are different Corynebacteria friendly together. Orange is Corynebacterium minutissimum, and cotton-like structures on the hair shafts is Corynebacterium tenuis, which cause trichomycosis axillaris. UV helps to detect facial sebum distribution too. We can see that this orange orange red, it is Cutibacterium acnes and causes progressive macular hypomelanosis. In summary, Pseudomonas aeruginosa, Corynebacteria, and Cutibacterium acnes are visible under UV. Itchy lesions. In addition to the tattoo, it's also difficult to distinguish a rash. Dermoscopy is not helpful. But UV makes visible a yellow fluorescence due to the porphyrin piturialactone. It is tinea versicolor. Pityriasis versicolor, also known as tinea versicolor, is a common fungal infection of the skin caused by an overgrowth of a yeast called Malassezia. This yeast naturally lives on the skin, but under certain conditions, it can grow excessively and cause an infection. It's much more noticeable on dark skin than on light skin. Pityriasis versicolor is more visible in dark skin due to a thicker stratum corneum, more tonal filaments in the stratum granulosum, and more isolated melanosomes. Pityriasis versicolor means we can see different colors. The primary treatment for pityriasis versicolor involves topical antifungals such as ketoconazole, clotrimazole. For more widespread or persistent cases, oral antifungal medications like fluconazole or itraconazole may be prescribed. We can see beautiful fluorescence due to the porphyrin piturialactone. Microsporum will produce a blue-green fluorescence due to porphyrin theriidine. It is tinea capitis. Here is 5-year-old girl. Suspicion is tinea capitis. We can see just broken hair and scales. But UV helps us. We can see green fluorescence, and it is Microsporum canis. By UV, you can even detect the zigzag hairs. This Microsporum canis is an ectotrix fungus, and you can see this fluorescence. In summary, most dermatophytoses don't fluoresce, but some of them do. In the case of viral infections, the diagnosis of molluscum contagiosum is helpful. The cause of molluscum contagiosum is an infection of poxvirus family. Often the center of the papule contains a white patch of gourd-like material. This substance contains viral particles and necrotic cells that are dead or damaged. We can use UV also for surgical application, can we? Yes, there's some evidence. To remove lentigo maligna melanomas, UV light is used to outline the borders. A new preoperative technique called photodiagnosis uses methylaminolevulinate cream as a phosphor for basal cell carcinoma, and then it starts to illuminate like bright red fluorescence. Here is a BCC. Sometimes with basaliomas, we can see the gray area around this cancer, and it's visible just a UV light lamp. Here is a border with dermoscopy, and you can see that border with UV is much wider. But it is mandatory to do more comprehensive research on this field. There are two similar lesions. Is it good or bad? Does UV help us? First, you can see white keratin. It is benign seborrhoid keratosis. But second one, You can't see this white keratin. You can see by dermoscopy it's malignant melanoma, but UV helps more to see those borders. In summary, it's mandatory to do more comprehensive research on this field. I'm happy to share some unpublished tips or tricks too. I'm happy to share how to make scabious burrows more visible. And the rash elements of scabies include papules, vesicles, burrows, excoriations. And it's very easy how to make those burrows more visible. Just use a fluorescent marker and specific UV light. A fluorescent marker makes the burrows more visible. Sometimes the clinical signs are such and few that it's quite difficult to detect scabies which caused by the Sarcoptes scabiei mite, but UV helps. And I tried several fluorescent markers. Yellow marker is even brighter. You can see burrows better. Delta sign is a little triangle like a paper plane, and that's the end of the track. Burrows are more visible. Other complications too, yes, of course, like wrong interpretations. Conclusions. Ultraviolet fluorescent dermoscopy is helpful in the diagnosis of several infections, inflammatory and neoplastic dermatology conditions. It is easy to use, safe, and gives fast results. Helps reveal the invisible. Take home message 2. Colors are very important. Thank you. The people in this Congress are united by passion. Together we are stronger. Thank you.
So we're gonna see if he's there. I wanted to ask with Professor Schwartz, because I know we have to wait.